All right, I think we're going to get started. So I've given a couple minutes for people to come in. We have a very special grand rounds this afternoon. So we have our annual diabetes workshop. So Erin, Newkirk, and Allison Behrens will be presenting on closing the loop in type 2 diabetes. And I know many of us work regularly with Erin and Allison in clinic, but I'll go ahead and just give the formal introductions for each of them. So Erin received her PharmD degree from the University of Wisconsin and then completed a specialized residency in ambulatory care at the VA in Madison. So she has been working as a clinical pharmacist in our endocrinology clinics at the main campus for more than 15 years now. So her clinical interests include the management of patients with type 1 and type 2 diabetes, diabetes during pregnancy, and the medical management of patients with obesity. She has a special interest in expanding the use of diabetes technology and a passion for improving diabetes outcomes. So she's currently the Wisconsin coordinating body lead for the Association of Diabetes Care and Education Specialists. And then I think Erin and Allison will be presenting after Erin. And so Allison has been a clinical pharmacist in ambulatory care. She received her Bachelor's of Science in Pharmaceutical Sciences and PharmD from the University of Wisconsin, Madison. So then she completed 2 years of residency at UNC Health, and then she joined our Freighter Endocrinology Clinics in August of 2022. So I think we started around the same time. Yeah. So her interests include diabetes and weight management as well. So I think this is actually one of the most helpful and practical grand rounds of the year. So I'm kind of looking forward to your workshop.
All right, thank you everyone for being here this afternoon. So as Dr. Zhang had said, we're talking about closing the loop in type 2 diabetes, so just really focusing on automated insulin delivery therapy for patients that are currently on multiple daily injections. So I do have disclosure where I'm on the Insulin Speakers Bureau and Pure On Demand, and Allison doesn't have any disclosures. So there are 3 insulin pumps that are now approved and cleared through for type 2 diabetes. So we're going to go through some of the clinical trial data and then bring in some cases at the end, kind of in a breakout session. And in between there, we'll talk about just optimizing some of the settings with these pumps. So one of the biggest things I think with people that struggle with multiple daily injections with type 2 diabetes is a lot of times we're finding their A1C goals aren't being met. And we'll talk in detail about the clinical trial data and showing how, and some of the experience that we've had where patients can get to goal with these different ways to deliver insulin using an automated insulin delivery system. Of course, having multiple daily injections a day is more complex compared to now with these systems. Some patients can give their bolus from their phone and, more conveniences, as well as when patients are on injections, of course, with like the basal insulin. I had someone this morning that essentially was struggling with the glucose rising in the morning, but was on Tresiba. And so it's challenging to adjust for that versus automated insulin delivery would help with that scenario. And then, of course, the quality of life and injection burden that patients can struggle with. So I think there's some misconceptions with using these systems with patients with type 2 diabetes. Some thought is that there's requirement of carb counting, and we're finding more and more in the trial data shows that even do a simplified carb method where someone's just selecting small, medium, and large meal, or even just a fixed dose works really well in improving time and range. Some think too that maybe the patients on the total daily amount of insulin is so high between their basal and bolus amount, and so some of the pumps only hold 200 units of insulin or even 300, and so there's concerns with that. But a lot of the times we see a pretty significant reduction as patients are moving on to automated insulin delivery, and then we have things that we can do off-label as well to help them. And then kind of historically with automated insulin delivery, the thought was that maybe patients should try to improve their glucose and show kind of commitment. But really, I think if they have problem-solving skills, anyone deserves the chance to deliver insulin through an insulin pump. And the coverage with the clearance of the 3 different pumps, that's coverage is improving. There's some limitations with C-peptide that we'll talk about in a few slides. So in terms of the ADA guidelines, looking at diabetes technology standards of care specific to type 2 diabetes, insulin pump therapy can be offered to diabetes management for youth and adults on multiple daily injections with type 2 diabetes who are capable of using the device. And the choice of the device should be based on individual circumstances, preferences, and needs, and that's at a level A. So I'm kind of excited to see what the upcoming 2026 guidelines say in terms of the term, in terms of offered or recommended, and how that will change with time. So our 3 different FDA cleared pumps are the MiniMed 780G, the Omnipod 5, and the Tandem. So I'm going to first start talking about the Tandem pump, and then Allison's going to cover Omnipod 5 and the MiniMed 780G. Before we get into Tandem, I do want to just mention in terms of criteria, there's lab criteria for Medicare patients that patients have to have a C-peptide level checked if it goes through the medical benefit. So the pump that is through the pharmacy benefit is Omnipod 5, and there's no lab requirement. So I find that a lot of patients are moving towards Omnipod 1 because of that and meeting the criteria, and then 2, some people are just choosing that because it's a tubeless pump. So if someone wants to use Tandem or Medtronic, they have to have a fasting C-peptide level less or greater than 110% of the lower limit of normal. So commercial patients, this shouldn't be an issue. All right, so moving on to Tandem. It's kind of fascinating. The first automated insulin delivery system, even in type 1 diabetes, it's only been 10 years. Just think about like the changes we hear about almost weekly sometimes with some of these updates. So specific to Tandem, the t:slim X2 was FDA cleared for type 1 diabetes in 2019. So essentially 6 years ago. And then this last February got approval in type 2 diabetes for 18 and older. So we're going to just spend a few slides talking about the study that cleared using this system in type 2 diabetes. So it was a 13-week multi-center randomized control trial, and that's the difference between the other 2 studies is this had a control group. There was 319 participants. Their mean age was 58, duration of diabetes 18 years, and the mean A1C at baseline for the AID group was 8.2 and then 8.1% for the control group. A large portion of the patients were Caucasian at 70%, and the majority of the patients were on multiple daily injections, so they weren't previously on a pump. Pretty high amount of patients using CGM, 70%. I'd love to see that globally. And 20% had a bolus strategy of carb counting, so 80% were not carb counting in this study. In terms of other agents that we use with type 2 diabetes, there was a good portion of patients on a GLP-1, also a decent amount, about a third on a SGL2, and then 20% on both. The primary outcome at 13 weeks was looking at the reduction in A1C, and the A1C and the AID group dropped by 0.9% compared to the control group of 0.3. And then a secondary outcome was looking at the time in range, and that increased by 16% in the AID group versus 1% in the control group. And there was no difference in time below range. And that's what definitely we're seeing with patients using these systems in type 2 diabetes, that lows are definitely not much of a concern most of the time. This study was funded by Tandem Diabetes Care. So just another way to kind of look at the outcomes here is you can see the difference with the A1C for the primary outcome, but also with the subgroup analysis that we see this with type 1 diabetes too. The patients with the higher A1C get the most benefit. And then, of course, patients that aren't on other therapies like the GLP-1 and SGL2 inhibitors also had the most benefit. But the treatment effect for all of these groups essentially favored AID. And then some additional secondary outcomes. I mentioned kind of some of the hesitation might be the total daily insulin patients are taking with multiple daily injections. And this trial wasn't quite as significant, but there was a difference in reduction of 8 units per day for the AID group, and then an increase of 2 units in the CGM group, so a difference of 10. And I feel like clinically I'm seeing this to be more significant than that. With the carb counting, this is just a depiction of the breakdown of the A1C based on different bolus strategies. So I had mentioned that roughly 20% of the patients were using the carb counting method, and they saw a reduction of 0.9%. If they used that small, medium, and large carb entry, it was 1.1%. If they used more of a unit-based entry, it was 0.8, and then other group was 0.9. So no matter what strategy, there was a good reduction in A1C. And then just to tie it back to the Medicare criteria with C-peptide, last week Tandem published some data looking at the differences of patients that had a high C-peptide versus a low C-peptide. So in the lighter gray is the baseline, and then the darker gray is at 13 weeks. And whether the patients had the CMS criteria for a high C-peptide or a low C-peptide, there was a 0.8% reduction. So that shouldn't really be criteria to determine whether patients can get these. Now, whether this will change Medicare's criteria is another story, but hopefully with time. So in terms of specifically applying Tandem to use in type 2 diabetes, the data shows us there's a greater reduction in A1C, and an increase in time and range in the AID group. There was, I didn't present on that, but there really wasn't, there was low baseline hypoglycemia, and that stayed low throughout the trial. And then when patients are even on these standards therapies like SGLT2 inhibitors and GLP-1s, their A1C reduction can be additive. And then in terms of previous experience with carb counting, that's really not a requirement to move forward with getting an AID system prescribed. There may be some limitations with people being able to use this pump from a coverage standpoint, depending upon their insurance from a C-peptide standpoint, though. So in terms of how they work, how many of you are aware that the Tandem has a software upgrade where it has the Control IQ Plus? So that's the newest one. We'll kind of walk through that in a few slides, but that's their most recent algorithm essentially. But we have two options with Tandem. So on the left is the Tandem X2 pump, and that can work with the Libre 3 Plus now, as well as the Dexcom G6 and G7. It will not be working with the 15-day until 2026. And then the Mobi is on the right, and that works just with the Dexcom products and not currently with the Libre. So in terms of kind of this algorithm, you can see here that we're trying to target our patients between 180 and 70 as much as possible. This is a pump system that doesn't have a target number. It actually has a target range. So between 112.5 and 160 is where it's trying to maintain. So if it's predicted to maintain in that range, then it's just running that basal rate that's programmed, because this pump uses the manual basal rates. But if it's predicted 30 minutes in the future where it's going to start decreasing below 112.5, then the basal will decrease. If it's predicted to go below 70, it'll actually stop or pause the insulin. And then if it's predicted to go above 160, it'll start ramping up that basal rate. And then there also, if it's predicted to go above 180, which is here, it would give an autocorrection. So to kind of further expand on the different kind of modes that are offered, so the Control IQ Plus, as I just mentioned, the target range is 112.5 to 160, and this is essentially toggled on. And patients really don't get kicked out of auto mode in this pump unless they don't have a CGM on. And then, as I just mentioned, the background insulin will increase if it's predicted to go above 160, decrease if predicted to go less than 112.5, and then stop at predicted to go below 70. And then those auto corrections happen if it's predicted to go above 180. The Control IQ Plus features, the biggest thing was the temp basal option. So that's something I feel like people that were used to use this option in the past before automated insulin delivery. And so this is the only system that will allow that, because it does use the manual basal rates. And so patients can set a temp basal option. And then the extended bolus option has been extended to up to 8 hours. And we'll talk a little bit more about that on a couple slides. Sleep mode is that targeting, instead of up to 160, it only targets from 112.5 to 120. And this can either be manual set or it could be scheduled, and there can be up to 2 sleep schedules. And then when they're in this mode, there's no auto corrections happening. The exercise activity mode is targeting between 140 and 160, and then it would suspend if predicted to go below 80. Auto corrections do happen when patients select exercise activity. With the X2 version of the pump, they can set an amount of time anywhere between 30 minutes and 8 hours. The Mobi, they still have to go in and turn it off, which hopefully that's added to the Mobi soon. And with exercise activity to work, if there's trying to prevent a drop with exercise, that needs to be turned on 60 to 90 minutes ahead of time. And then patients, in addition, could do a temporary basal. So there's kind of a couple things that they can do to help lower the insulin related to activity. One other nice benefit with Tandem is that there can be multiple personal profiles. I tend to use this most often in patients that are pregnant. So when they can keep their pre-pregnancy settings, and then we'll work with adjusting their pregnancy settings. And then when they deliver, they just go back, and it's kind of an easy switch. Other scenarios where this may come into play, people that have glucose rising with their menses or steroids, those are other scenarios where different profiles might be beneficial. And then that temp basal rate. So once again, that can be turned on when automation is on or when Control-IQ is on. And they can set that for anywhere from 0% to 250%. And it can be set anywhere from 15 minutes to 72 hours. And then it can either be manually stopped or programmed. So I think this is a new great option for patients. The extended bolus was a feature that Tandem has had on their pump system, but the difference is the duration. Patients can now extend this up to 8 hours instead of 2 hours. So that extended bolus feature comes into play a lot of times. Classic example is pizza or those meals that are higher in fat and protein that kind of initially end up resulting in their glucose to drop and then have a delayed high. In terms of settings specific to type 2 diabetes, when patients now get the Tandem pump, it will ask if they're switching from multiple daily injections, and they would just have to enter their total daily insulin and weight into the pump. Of course, we want the patients working with our educator team to get started. However, I really try to take the individual in front of me when deciding which route to go, in terms of you could take the total daily insulin amount and just use that, and you could you just do 75% of that, or you could do a weight-based dose, or you could average the two. And I think it really plays into if you're feeling like your patient is taking their prescribed regimen, then maybe it makes most sense to use their total daily dose, versus if you're kind of thinking they're probably missing a bunch of doses and their A1C is pretty high, they're probably not using the injections as prescribed, and so then maybe you want to do a more conservative approach and do weight-based. And if you're kind of in between, you could average them. So one of the big things, and this applies actually to type 1 diabetes as well, is Tandem published a study looking at different correction factor quartiles. So historically, we always use, and when we start patients on a pump, we use for the correction factor the 1700 rule. So we take 1700 divided by their total daily insulin dose. With this system, the correction factor is kind of a significant part of the algorithm, because the correction factor is taken into the basal, it's taken into account the auto corrections, and then it's also taken into account user-initiated boluses. And so we really should prioritize the correction factor to maximize time and range. And when they looked at this, you can see this graph here to the right, there's different correction factor ranges. So 2422, and then a range here, 1948 to 2422, a range from 1580 to 1948, and then less than 1580, and you can see the highest time in range is with the most aggressive correction factor calculation at 1580. And then you can see with this darker blue line that it really didn't increase lows. So this information kind of shows that prioritizing the correction factor can help improve the time in range without causing an increase in time below range. So they're recommending when you're trying to optimize settings and you're trying to look at changes that you could make, that would be something to consider, is using that 1580 rule. Then there's also recommendations to consider even a 1330 rule for carb ratio instead of the 450. The data that they found from this this information, though, was that yes, making the carb ratio more aggressive and using the 330 rule will help improve time in range, but it also probably will increase time below range. Similarly, if we're more aggressive with those basal rates. So in terms of the reports, we have the overview report, the daily report, and then the pump setting reports that we get from Tandem source. So we want to look to make sure that the patient is using the CGM and we have enough data, and that they're running in control IQ regularly. So that's B there up on the right, 97%. And then how often are they bolusing? So that's C here. So this patient is bolusing 11 boluses per day. And you can also see essentially the carbs are at 137. And then the glucose statistics that we're used to from every CGM essentially report is shown in the box surrounded by D. And then, of course, the AGP graph that can help us kind of visually find to see if there's highs or lows happening. So in terms of the small pictures, then we could go into, to look for highs and lows, we can look at the daily graph. And just to orient you to this, so of course this is the CGM tracing, and then if the patient has sleep mode on, it's going to be those Z's. If someone uses exercise activity, there'll be that little running guy. And then there's different symbols, which is nice since they moved to source, where you can kind of see what each little insulin drop means. So if it's just a light blue, which isn't depicted here, that would just be food only. If they were only correcting, it would be a little bit darker blue. If it's a food and correction, which would be here, it's both dark blue and light blue. And then if the user gave a correction dose, that would be the dark blue. So you can see here that the basal goes up and down. The basal rate is set at 0.8 here, but sometimes it runs below there. Other times it is completely suspended with the red here. So in terms of kind of evaluating the report, of course, we always want to prioritize hypoglycemia and make sure we eliminate that first. So if they're having overnight hypoglycemia, we may need to reduce that basal rate. If they're having lows following meal times, we may need to look at essentially their bolus patterns in terms of, are they entering carbs late, or are they timing it ahead of the meal? Then maybe we need to weaken the insulin to carb ratio. If it's following a high glucose, we need to make sure that they're not overriding. If you're seeing carb entries at the peak of a glucose, is that patient entering potentially fake carbs? Or do we actually need to weaken the insulin sensitivity factor? And then if it's related to exercise, making sure they use the exercise activity feature, and then that temp basal rate could be considered as well. From a high standpoint, we want to make sure a lot of the improved time and range really comes from patients programming that sleep activity. So we'd like to make sure that's programmed over when they're sleeping. And then if they're going high overnight, we may need to raise that basal rate. Of course, if they're high related to the meal bolus, we can strengthen that insulin to carb ratio. If the highs follow the lows, maybe they are treating with too much. And that's something that I feel like is common with automated insulin delivery, is people are trained for so long to take 15 grams of fast-acting sugars, and that tends to be too much because the pump in advance is reducing the background insulin. So patients need more towards 5 to 10 grams. And then, of course, if it was after a correction bolus that they're going high, we could strengthen that insulin to carb or insulin sensitivity factor or correction factor. And that's where you could, I sometimes calculate out, okay, where are we at? And you could use that 1580 rule. So just to kind of summarize some of those tips, this is the pump that you can adjust basal rates, correction factor, carb ratio. Just talked about correction factor being one of kind of the most impact on the algorithm. There's the different sleep schedule and exercise activity. The new Control-IQ Plus features are that temp basal option and the extended bolus feature up to 8 hours. And then patients may benefit from having multiple profiles. Some patients might even benefit if they're working construction during the weekdays, but kind of sedentary in the weekends. They could flop between profiles for that as well. So just a few other updates that I wanted to point out. I already mentioned the latest software upgrade. The Control-IQ Plus version was 7.9, and they've subsequently added another software update, which essentially allows the Libre 3 Plus to be used with this system. And then the other thing, some people using Dexcom kind of soak the sensor. So because there's that 12-hour grace period with Dexcom, people place the new sensor where the current one is still hooked up to their pump, just to kind of have it adjust or soak to their body so the accuracy is better. With that, there was the old, before the 7.10.2 software, there was some errors in the system where it was giving insulin. And so we do want to make sure anytime there's software upgrades, it's just important to have patients do that, even if they're not planning to, say, use the Libre 3 Plus. There could be other things that are part of that upgrade. Tandem is trying to get into the pharmacy phase for ordering supplies. So some patients might be requesting supplies to go to Aspen Pharmacy now, which, of course, being a pharmacist, I'm pro pharmacy, but I think all of us can agree that working with pharmacies compared to distributors is a much more pleasant experience. And then the biggest thing that was cleared by the FDA but not available, but we want to make sure our patients know, because hopefully early in 2026 this will be an option. There's a steady set infusion set, and this is an infusion set that's going to last 7 days. And the study information for the use, looking at 3,000 patients over 14 weeks, had a 94% survival at 7 days, which I think is pretty good. And the biggest thing is that it's easier to use. It's kind of more of like the concept of applying a CGM, like the Dexcoms and the Libre nowadays, compared to, the maneuvering of the infusion sets currently. And then the reliability is also supposedly improved, and because there's 2 cannula materials. There's on the inside it's stainless steel, so hopefully that helps prevent the kinking, as well as potentially preventing some skin irritation and things. And then on the outside of the cannula, it's actually a soft material, and it has 4 different ports. So insulin will be administered into the body through 4 ports. So if there's one clogging or issue with one of them, there'll be the 3 other ones that could help deliver. So I think that hopefully it turns out to be as good as it sounds.
Going to be 4 cannulas?
What was that?
Is that going to be 4 cannulas?
No, it's just like little holes where insulin, yeah.
Still 1 cannula?
Yeah, yeah. So, yep, it just has ports within the cannula, yeah. And there's a visual of what that looks like here, so. And then I'm going to turn it over to Allison.
All right, next we'll be talking about the Omnipod 5 system use in type 2 diabetes, similar to what Erin discussed with the Tandem. So looking at the timeline for the Omnipod 5 is a little bit newer to the market, with its first approval in January of 2022 for those age 6 years and older. Later that year, it was expanded to those 2 years and older, all with type 1 diabetes. Most recently, it did get extended to patients 18 years and older with type 2 diabetes starting in August of 2024, and was our first pump for the indication of type 2 diabetes to come to market. This was the result of the Secure 2D trial, which we'll discuss in more detail on the next slide. So similar to the other studies that we'll see, the SECURE-2D study was a 13-week single-arm prospective non-randomized controlled trial. Of note, it did not have a control group in comparison like the Tandem group did. So it was just a run-in period compared to its results 13 days later or 13 weeks later. It included 305 participants with an average duration of diabetes for 17 years and an A1C at baseline of 8.2%. The population was more ethnically diverse than what we see in some of our other studies, with 24% of the patients being Black and 22% being Hispanic or Latino. Many patients were on a CGM at baseline and maybe higher than what we see in our general population at 62% using a CGM already. A lot of patients were also using non-insulin therapy such as a GLP-1 or SGLT2 at 72%. And then similar to what we saw in the last trial, 84% of the patients did not carb count at the time of entry into the study, and 94% had never been on a pump before. These patients were required to be on insulin prior to the trial and had to be on insulin for 3 months in advance, but that could have been a mix of like MDI, or it could have been a basal only without any bolus insulin, or even on an insulin pump. Primary outcome was the change in A1C at 13 weeks. Again, in comparison to itself, they looked at like a 14-day standard run-in period where they did some data gathering, looked at CGM data, and established a carb regimen for them, or a mealtime regimen for them. But that regimen was variable. So patients could have been on a carb counting regimen. They could have also been on like a meal estimation regimen, small, medium, and large. They could have been on a fixed regimen or done correction only dosing. We did see an improvement in A1C with a difference of 0.8% 13 weeks later. Secondary outcomes did look at time in range, and we saw a time in range increase by 20% in the AID group. And again, there was no difference in time below range. And this study was funded by Insulet, who makes Omnipod. So here's just kind of another visual of the primary outcome, where you do see that decrease in A1C from 8.2% to 7.4%. That was statistically significant for both non-inferiority, and then they also did run it for superiority. The improvement was seen with or without the use of GLP-1s and SGLT2s, and regardless of the pre-trial mealtime regimen. So kind of like what we saw in the Tandem, that did stand the test regardless of how they were dosing their mealtime insulin. Some exploratory outcomes that are of interest. So total daily dose of insulin did decrease, similar to what we saw in the Tandem trial. So at baseline, these patients were on average using 0.8 units per kilogram per day, and this decreased to 0.57 units per kilogram per day by the end of the trial. And that was statistically significant. This is, something that's probably of even more importance with this system compared to some of the other systems, just due to the size of insulin that's allowed in the Omnipods. The Omnipod only holds 200 units of insulin. So for patients with type 2 diabetes who are more insulin resistant, or possibly have a higher baseline weight, they could be changing their pods very, very frequently. If they're on a dose of, or if they're using 0.8 units per kilogram per day. So thinking about this mathematically, a 150 kilogram patient would be would be using 120 units of insulin per day, changing it as frequently as every 1.5 days. We'll talk about some possible off-label uses of U200 towards the very end of our presentation today, and maybe that would be consideration. However, I think this study does show some promise that their requirements could go quite down. So that same 150 kilogram patient, if their settings decrease to 0.57 units per kilogram per day, now may only need 86 units of insulin per day, and they need to change it every 2.3 days, which is much closer to the life of the whole pod. Something interesting is that weight did actually increase to a statistically significant amount in this trial, increasing by about 0.8 kilograms. Now that's statistically significant. Is it clinically significant? I'm not sure, but we still did see the insulin decrease even with this weight gain. So some applications to clinical practice. So we saw an A1C reduction occur regardless of SGLT2 use or GLP-1 use, and can have additive benefit when added to these. Carb counting was not required, and patients were successful regardless of what regimen they used. Similar to what we see in the other trials, patients with the highest A1C did also tend to have the biggest improvement in their A1C lowering. The total daily dose of insulin did decrease by about 30% for these patients. And we didn't discuss this outcome, but patients felt there was a decrease in diabetes distress as well. So talking a little bit more about the Omnipod 5 system. So the Omnipod 5 works with various CGMs on the market, but it is important to know the CGM that the patient's working with because they communicate differently and have different requirements on if they can use a receiver, if they can use a smartphone, and what's exactly needed. So first we'll start with talking about the Dexcom G6 and G7 system. So this was kind of what initially was available for patients that were interested in the Omnipod. Now, what's tricky about this is the Dexcom G6 and G7 only can communicate really with one device. And so they are sending their readings to the Dexcom via the transmitter. However, it can't also communicate, or it can't communicate with, getting the readings from the cell phone as well as giving it to the receiver. So these patients do need to have a compatible cell phone that's compatible with the Dexcom app itself to actually start and stop the sensor and then troubleshoot any problems. The pod or the Dexcom then sends that information to the pod, which then forwards that information up to the Omnipod receiver controller device and even maybe the smartphone app that they're using that. But this whole kind of squared picture is needed to close the loop. So this can be a hindrance for patients that don't have either a smartphone at all or don't have a compatible smartphone. They would not be able to use the Dexcom G6 and G7, particularly with the Omnipod. Until
one additional thing, so the G7 15-day was just made available, and you can now use it without.
Yeah, so I actually added this in. So thank you. Yeah, so as Erin alluded to, that did kind of close that up. So now it lasts for a little bit longer, and you don't need your cell phone, so that kind of solves that. And then the Omnipod 5 also works with the Libre 2 Plus system, and this one also does not require the cell phone, communicates a little bit differently. So for patients that don't have a cell phone, now they have some options for the Dexcom or the Libre system. All right, so then we'll talk briefly about kind of how the algorithm works. So the biggest mode of automation with the Omnipod is in auto-basal automation. It does not give any auto corrections. So in automation, it will increase or decrease or pause insulin delivery every 5 minutes. It is kind of an adaptive system, so it is adjusting the aggressiveness of the basal given based off of total daily dose of insulin, CGM trends, and where it predicts the glucose will be in 60 minutes. It takes a little bit of time for the pod to learn what the patient's requirements are. So it will first, when initiating it, will start by running at whatever the program settings are, and it will do that for the first 48 hours and until the first pod change has been completed. After that time, then it will use those factors to start adjusting what the basal settings will be. However, it can take multiple pod changes because it's learning with each pod change the requirements. So we will see that patients' sugar and glucose levels should start to progressively improve, but it can take a few weeks before they're really kind of at their optimized settings. Looking at glucose targets. So glucose targets is kind of the primary parameter that affects automation. So a glucose target, there's glucose targets and then there's the glucose correct above targets. The glucose target itself is the amount that the automated basal is targeting. Compared to the glucose correct above targets, applies that when you're giving a correction, when the patient's entering in a correction, it's telling the patient, or it's telling the pod not to correct unless the glucose is exceeding a certain value. Targets range from 110 to 150 and can be set anywhere in in increments of 10 between those two values. And it can be set up to 8 different targets per day. And that applies with the glucose correct above targets as well. And so here you kind of just see, I'm sorry, I lost my train of thought there, but yes, so those are kind of our glucose targets. Like I said, too, with the glucose correct above targets, where that applies is like if a patient has a glucose target of 110, a correct above of 140, while automation, and if they're 130, automation of the basal rate may be kicking in because it's trying to get them to the 110. However, if they go to give themselves a correction dose, the pump may say that they don't actually need one because they have not exceeded their correct above target yet. Looking at the bolus calculator, so when the patient goes to give themselves a correction, the things that they'll need to input is if they're eating any carbs, what their glucose value is, and then it will give them a recommendation. What's important to note is that the patient kind of has two options for entering in their glucose. They can either manually type it in that box in the middle, or they can hit that use CGM button, which is highlighted in that red box. It is really important that the patient knows to use the use CGM rather than manually typing that in. And that's because the algorithm is going to take into account the trend in which the glucose is heading and increase or decrease the suggested bolus, or potentially keep it the same depending on that trend. So you'll see in the purple box below, if things are running steady, it will have the patient give the glucose based off of whatever the calculated correction is. However, if it sees that the CGM value is trending up, it could increase the bolus amount to as much as up to 30% for the suggested bolus. And then if it's trending down, it may even say no units are needed. It could decrease it up to 100%. So this is important to try to, be more aggressive with treating those highs and to be less aggressive to avoid severe hypoglycemia. Additionally, insulin on board is taken into account with these trending values, where we would lose that calculation with, just doing the stagnant glucose value. Something that I think I didn't even realize this until I've been using the pump for a little while, but one of the really important things to know is that the importance of total daily insulin in terms of the aggressiveness of the pump. So the pump is that adaptive basal. That's what you're, really having the automation kick in. And so that is primarily using your total daily dose of insulin to figure out how aggressive or not aggressive it should be. So indirectly, what can impact the total daily dose of insulin is your bolus settings. So if a patient is under bolusing and not meeting their targets, their total daily dose of insulin may be lower than what it actually needs to be, which then the pod will use that total daily dose of insulin to adapt its basal further, and their control may not be fully optimized. So bolus settings are really, really important to hone in on and make sure that the patient's appropriately using their bolus settings to best have our total daily dose of insulin impact, the automation of the algorithm. And then as a reminder, the target glucose is really the only setting that directly impacts the automated insulin delivery. A handy feature that Omnipod has recently come with is minimizing, the amount of work that a patient has to do in calculating with the option of custom food. I think this is beneficial for patients with type 1 diabetes, but I really do see that this could be extremely beneficial for patients with type 2 diabetes that are not familiar with carb counting or just haven't gotten the routine of doing it. To allow them to kind of better match their insulin to their carb amount without maybe having to do all of the math and everything that comes with carb counting. So patients can log in to this custom food option, foods that they commonly eat. So here you see on the example, like someone eats like a banana and has that loaded in at 27 grams and cereal loaded in at 15 grams for like their common serving. Now, rather than a patient, maybe some days they eat a banana, some days they eat cereal, some days they eat a combo, rather than them having to like kind of constantly calculate that, they can just select those common foods that they're eating, and then it will tell the pump that they're eating those 42 grams of carbs for the cereal and the banana. Additionally, they can customize like a meal estimation regimen and program it by meal size, so like small, medium, large, or program it by the type of meal that they're eating, breakfast, lunch, and dinner, and program like those, pre-program what the estimated carb amount would be. So I can see this being particularly beneficial for patients that, are sensitive to the amount of carbs that they're eating, but aren't totally ready to carb count, or, don't want to take on the burden of carb counting and stuff, that they could just select that I'm eating a medium meal or I'm eating my standard breakfast. The Omnipod order form is built out to kind of pre-populate itself, which is nice. So the areas of entry that the clinician or whoever's filling out the form will need is the current weight and their total daily dose of insulin. Then similar to what we saw with the Tandem pump, it will break it down into 3 different options. The total daily dose of insulin with a 25% reduction, the weight-based dosing, or it will average out those two. And then you can pick which one you want to go with, and then it will kind of just, if you're filling it out online, it will pre-populate all the settings accordingly based off of which starting dose you choose. Like we saw with Tandem, Omnipod has also published some data on where they think the optimized settings are. There's been some larger real-world studies with up to almost 70,000 patients included in this retrospective analysis. Plus, there were some internal data that Omnipod has on their website as well to kind of come up with what these optimized settings are. On the initial order form, we see that target glucose is 110, insulin to carb ratio is a 400 rule, correction factor is a 1700 rule. Now, some of those, the real world study looked at kind of truncating patients out into groups of 110 as the target, 120 as the target, and then somewhere in the range of 130 to 150. And similarly, what we saw in Tandem, there was a big improvement, the more aggressive that they were with the target glucose in time and range, and not a big increase in time below range. So now their optimized settings that they're recommending is 110 for patients to have the most aggressive control with the best time in range. Similarly, some of the other data that they've published has suggested that an insulin to carb ratio of less than 350 and a correction factor of less than 1,500 can help to optimize postprandial control and user-initiated boluses. So then kind of based off of some of these results is some breaking news that actually came out this morning. So brand new is that they are planning on updating their software to have it launch in the beginning or the first half of 2026. And with this software upgrades are going to come things like a new target. So new target of 100 rather than 110. So patients can have more aggressive control. And then also it will keep patients in automated mode longer. One thing that we often see is that when patients have high glucose, what can happen is that the automation will deliver what it determines to be its maximum basal amount. If that maximum basal amount is running for too long, it will give the patient a warning, it will kick them into manual mode, and then they will stay in manual mode until they go back and they address that and say, yes, I'm fixing it, I understand, please put me back in automated mode. A lot of times patients don't even realize that they've switched from automated mode to manual mode, and then we see that in clinic when we're looking at their reports and noticing that they've spent a lot of time in automated mode or in manual mode, and they don't end up switching back until they do their next pod change. With this new software upgrade, it's no longer going to make that forced switch from automated mode to manual mode. Patients will still be alerted that their glucose is high and has been high for a long time, and so that they're not totally missing if they have a clogged tubing or something or cannula that we're worried about them going into DK. So they still will be alerted, but they just will be able to maintain automated mode. Our 3 reports are very similar to what we see in our other pump systems, but we have the summary report, the weekly report, and the daily report that we'll look into a little more detail. Again, looking at big picture reasons. So CGM use, so we're striving for that to be at about 90% or greater. If a patient's consistently not meeting that 90%, can try to troubleshoot why. Is there a connection issue? So one of the important things with the Omnipod is that the sensor and that the pod itself are both on the same side of the body, so both on the front of the body, both on the back of the body. Patients are wearing them in different locations. They can be losing connection frequently. Are they having trouble with the duration of wear? Because now there's the Dexcom 15-day that they could be using it longer. Are they having skin irritation and are taking it off earlier? So trying to troubleshoot some of those things. Staying in automated mode too, as we just discussed, that's a big thing that I feel like people don't always realize that they're going into manual mode. Hopefully with some of these software upgrades that we'll start to see that improve, but also making the patient aware and making sure that they understand, to be watching for the manual mode versus automated mode and switching back into automated mode when needed. Are they bolusing for meals? Again, as we talked about, the bolusing for meals is really important for the adaptation, just so that they're getting the total daily dose of insulin needed and for their overall control for bolusing. Are their glucose targets being met? We see the time and range graph on this report, and then looking for patterns of highs and lows. Similarly, we can look at small pictures to orient you on this slide. We see very similar information that we see on the other pump reports, but you have your Dexcom, your CGM data here. Carb entries are shown in this teal box. Bolus doses are shown as these purple. If a patient is overriding the bolus on the daily report, you will see like an arrow that is darker purple showing that they increased or decreased it. You can see when you can't see their exact basal rate, but in this purple bar down here, you'll see if it's reached automated suspension is the red, or if it's that maximum delivery, which is this orangish color. And then you can see what mode they're running in. Here, this gray box with the split square is the automated limited mode. The blue box with the lightning bolt is the automated mode. And then if you see anything like yellow with like a gear symbol, that's when you know that they're in manual mode. So again, addressing hypoglycemia first, what can we do to address these things? So if they're having overnight hypoglycemia, we can raise the glucose target overnight. If they're having hypoglycemia related to a meal bolus, we can adjust the insulin to carb ratio if it's been within 2 hours after the meal. If they're having hypoglycemia following a high glucose, the user, what we want to watch out for is making sure that they're paying attention to kind of the insulin on board and that they're avoiding those insulin overrides, because they do have the option to override the bolus dose, but that can lead to a lot of hypoglycemia. And we'll discuss that or show that on the next slide. And then if hypoglycemia is related to exercise, there is an activity feature that they can turn on 1 to 2 hours before exercise to raise the glucose target to 150, as well as kind of decrease the trend with automation. Here's just an example of what it looks like when a patient does override. So you can see kind of those dark purple diamonds here, showing that the user gave additional or gave a higher than a recommended dose. And you can see what happened here is they had given their carb entry and the glucose started rising. They ended up entering in more carbs, which may have been more food, or it may have been that they were kind of panicking and trying to, bring the sugar down and entered some fake carbs. But then you see the succession of these of corrections given. There was no carbs associated with it because you're not seeing any green. When it was all said and done, you can see that they had 8 units of insulin on board, and with their most recent bolus, they gave themselves 3 units of insulin. So these additive effects dropped and caused them to have a low. Looking at addressing hyperglycemia, so if they're having overnight hyperglycemia, our options are to lower the glucose target, right now as low as 110, but in the future 100. If it's hyperglycemia related to the mealtime bolus, they can assess if a mealtime bolus was missed. They can bolus, make sure that they're bolusing their timing is correct at 15 minutes before a meal. Strengthen their insulin to carb ratio by 10 to 20% if it's elevated 2 hours after eating. If the hyperglycemia is following a low, similar to what we just talked about, making sure that they're not overtrading the glucose and or overtrading their lows and treating with 5 to 10 grams of carbs instead of a full 15. And then after a correction bolus was given, we could always strengthen the ICR. All right. So just looking at general Omnipod 5 tips. So the timing of the bolus, 10 to 15 minutes before is really important to make sure they're getting their carb entry in as needed or, correctly. They should not be overriding the bolus calculator and correct highs only if necessary. Using that use CGM button is really important for allowing the trend of the CGM to be taken into account. Always placing the pod on the same line, in the direct line of sight as the CGM so that there's not a loss of connection. And then treating hypoglycemia with 5 to 10 grams of carbs instead of the full 15. Lastly, we'll move into the Medtronic 780G system and some of the data that we see with this too. So as Erin discussed, the first automated insulin delivery pump was approved back in 2016. This was the 780G with the Guardian 3. Since that time, Medtronic's had some updates to their system, some newer pumps, and now we currently have the 780G system, which was just approved in 2023, and then as soon as September of 2025, received approval for type 2 diabetes for those 18 years and older. And also, it used to just be approved with the Guardian 4 sensor, but now we have 3 sensor options that we'll discuss on future slides. This was the results of the Impact 2D study. The Impact 2D study was a much shorter and smaller trial than what we've seen for the Tandem studies and the Omnipod studies. So it was a 90-day, single-arm, non-randomized, open-label study conducted at 13 sites in the U.S. It started with a 21-day run-in period, which was when patients were able to kind of start up the pump and were on a manual mode, followed by a 90-day study period in which automation was turned on. A total of 95 participants were included with an average duration of diabetes of 18.6 years and an A1C of 7.9%. It was a less ethnically diverse population with 76% of patients being white. Insulin delivery methods prior to trial included multiple daily doses of insulin with 61% of patients dosing insulin that way, followed by 20% of patients with an insulin pump with CGM use, 9.5% of patients with an insulin pump without insulin or CGM use, and then finally 7.4% were already on automated insulin delivery. Primary outcomes included time and range change and A1C change. We did see an improvement in time and range from the run-in period to the end of the study period of 7.2%, and then an A1C decrease by 0.71%. Additional secondary outcomes that they looked at, they did stratify things into, time above range, time and was a time and tight range, which they defined as 70 to 140, increased by 9.2%, and then time above range, so anything above 180, did decrease by 7.1%. There was no change in time below range, and there wasn't a significant change in weight or. And this was also funded by the company that makes it, Medtronic. So here's just kind of more visualization of those primary outcomes. You can see on the right half of those graphs is the overall change of time and range and improving. And similar to what we've seen with the other trials, and I'll show on the next slide too, they did stratify it out by A1C, and we saw that those with the higher A1Cs, so they said anything above 8%, did have the greatest improvement in time and range compared to lower A1C values. Change in A1C was a decrease of 0.71%. So additional outcomes here, you can kind of see those different time and range targets time and range based off of the CGM or of the A1C at baseline. And each subgroup had an improvement in time and range and time and tight range. And then each subgroup also had a decrease in sensor glucose and percent time above range with really no difference in time below range. They did subgroup analysis for those with GLP-1 or SGLT2 use, and they found that the mean A1C decreased with the use of SGLT2s or GLP-1s, but it also decreased for non-users. So it had an additive effect for those that were already using it, but we saw improvement regardless. Something pretty interesting to point out here compared to the other two trials where we saw a decrease in insulin requirements, we actually did see an increase in insulin requirements in the Medtronic study. So overall, there was an increase of 13.9 for these patients, and then those that had higher A1Cs, so above 8%, actually had an increase of 24.1 units in insulin. However, weight was not changed in this trial. So applications to clinical practice, so improvement in A1C and time in range and time above range, increased insulin delivery, and then additive benefit with glucose lower drugs. And then the 780G, we'll talk a little bit more about some of our sensor options, but historically with the Guardian sensors, sometimes the Medtronic system has been a little trickier to use with the sensors, but now the Instinct is going to operate a lot more like the Freestyle Libre 3 and may be more of an option of choice for patients. So how does the pump itself work? So we have the physical pump, and then that connects to the SmartGuard algorithm, which then will pair with one of three sensor options. Our three sensor options are the Guardian 4 sensor, which was the initial one that was been used with the 780G. It is a sensor that lasts for 7 days. It has a disposable sensor part, but a reusable transmitter. It does require a lot of overtape to apply, and the transmitter does have to be charged. And it's a two-handed insertion process. This is kind of simplified with the next Medtronic sensor made, which is the Simplera Sync sensor. This has a similar duration, so lasts 7 days, but it is a one-handed insertion method, and it looks much more like our patch-like CGMs that we're used to. So there's no over-tape required, and it's a completely disposable system. And then most recently, the Instinct sensor is available, which is made by Abbott and is essentially very, very similar to the Freestyle Libre 3 Plus sensor, but is just right now compatible with just the Medtronic 780G pump. So it has a 15-day wear, a 1-hour warm-up period. It's a one-handed insertion, and it works just like the Freestyle Libre 3, so disposable, no over-tape required. Patients can use any of these 3 sensors, and they, with their next refill or eligibility to get a sensor refilled, they can just request it through Medtronic to switch it. Looking at the SmartGuard algorithm, so this one's more automated than what we saw with the Omnipod. So it does have basal automation as well as bolus automation as well. So the basal automation is set by kind of the glucose target. And so we can choose targets of 100, 110, or 120. This target, though, unfortunately, can only be set for one target for an entire 24-hour period. And when it's initially started, it's defaulted to 100, which is kind of the recommended setting or the most aggressive setting. A caveat to this is that patients can use a temporary target, which is pre-programmed at 150 milligrams per deciliter. And this can be programmed anywhere between 30 minutes to 24 hours. And during that time, auto corrections are not administered. In terms of kind of that auto basal, so this is calculated from the total daily dose of insulin and is adjusting every 5 minutes based off of the CGM trend and aiming for that target glucose level that's set. Active insulin time is, something that's really important with this pump to set to 2 hours for the most aggressive control, which is maybe different than some of our other pump systems. Again, it's defaulted at 2 hours, and that can kind of be changed if the patient's having hypoglycemia. Target for autocorrections. So these autocorrections are kind of mini bolus doses that are given every 5 minutes as needed. These are also defaulted to on, and they can be turned off if a patient is having a lot of hypoglycemia. So Medtronic 780G markets their mealtime dosing as meal detection technology, and this uses current and past sugar trends to detect missed meal bolus or missed meal doses. It will give an autocorrection up to every 5 minutes if the glucose is above 120 and if it's already delivering the maximum basal. Autocorrections may also be stronger if the system detects that the glucose rises from a meal based off of the rate of change. It's meant to minimize hyperglycemia following meals and not entirely replace the need for mealtime dosing. So it still is really important that a patient is entering in their bolus dose pre-meal 10 to 15 minutes before eating for the most optimized control. There is some kind of, just with how aggressive this is and with it ramping up insulin, as quickly as every 5 minutes after the meal, there are some kind of recommendations that we give for patients where if they forget to bolus or they're late to their bolus for their meal and it's been within 30 minutes since they ate, they can still enter in carbs, but we recommend it by about 50%. If it's been more than 30 minutes, then they should just forego that meal, let the system kind of correct on its own, and then enter in carbs with their next meal. Optimizing settings. So the recommended settings for Medtronic are the active insulin time of 2 hours, the target of 100, auto corrections being turned on, and then ICR is a adjustable setting that the clinician can make and can kind of do that based off of the 2-hour postprandial glucose levels. Again, any of these can be weakened if they're having hypoglycemia. Looking at the reports, we have the overview, the daily report, and kind of just their general pump settings. So CGM use, again, we're looking for aiming for 90% of the time. This is where that Instinct sensor might really come in handy if a patient's, frequently, having issues with their sensor for whatever reason, or if, just that shorter duration of 7 days, it's causing them to change it and then not change it fast enough, switching to 15-day wear may be helpful for them. Automated mode, the Medtronic pump does include the SmartGuard exit reason, so it's nice you can kind of assess what's going on and why they're going out of automated mode. Again, if it's a CGM issue, this could be a potential benefit to switch the instinct sensor. The bolusing for meals, so we can review the number of manual boluses versus autocorrection and try to figure out if like their timing's appropriate or if they're missing those boluses altogether. And then our time and range graph is shown, and again, you can kind of start to assess the trends of when they're having hyper and hypoglycemia. Looking at the small picture reasons, looks pretty similar in this report. The thing is that it's just a smaller report where all the days are kind of lined up really close to each other compared to like some of those other stacked reports. But you still get the same information. You get their carb entry, you get their like correction doses. You can see those little purple, really small little purple boxes show anytime an auto correction is given, which you will see quite a bit of these kind of stacked up on each other because they're given as frequently as every 5 minutes. And then your CGM data is shown here. When looking at hypoglycemia, so if they're having overnight hypoglycemia, different things that we could do is increase the target glucose. However, again, keeping in mind that changing this would change it for the entire 24-hour period. So you can increase it as high as 120, but that will also impact their daytime control. You could consider using a temp target overnight to raise it to 150 without those auto corrections being given. If hypoglycemia is related to a mealtime bolus, we can assess carb counting accuracy and timing and meal composition. And if all of that seems to be pretty on par, then you can always weaken the ICR by 10 to 20%. If hypoglycemia is following a high glucose, can assess if lows are caused by like fake carb entries, and then educate the user to give a correction bolus via the bolus calculator rather than entering in fake carbs. And then if hypoglycemia is related to exercise, they can turn on that temporary target 1 to 2 hours before exercise. Addressing hyperglycemia, overnight hyperglycemia, we can decrease the target to as low as 100. We can decrease the active insulin time to 2 hours as well for more aggressive control. If hyperglycemia is related to a mealtime bolus, again, assess if it was a missed bolus and provide education. Assess the carb counting accuracy, bolus timing, meal composition, and again, if all else seems correct, you can increase the insulin carb ratio by 10 to 20%. If hyperglycemia is following a low glucose, can treat hypoglycemia with fewer carbs, so the 5 to 10 grams rather than the 15. Some general SmartGuard tips would be the timing of the bolus and making sure that they're not totally missing the boluses with this meal detection technology. Our most impactful settings are going to be the target, the active insulin time, and the ICR. They should not enter fake carbs, can turn on that temporary target 60 to 90 minutes in advance, and then just treating the mild hypoglycemia with less. So that kind of wraps up our individual pump systems. So one thing, as I alluded to a little bit earlier in this presentation, is just with specifically thinking about patients with type 2 diabetes, but also patients with type 1 diabetes that are more insulin resistant, we may see higher concentrations or higher amounts of insulin being needed. The Omnipod and the Tandem Mobi systems only hold 200 units. The Medtronic 780G and the Tandem T Slim pump hold 300 units. So as a patient starting to near 100 units per day of insulin, it might be worthwhile thinking about if switching to a concentrated insulin could be beneficial for this patient. So concentrated insulin is off-label currently in the pumps, but you know, it is still it's something that could help the patient. So if switching it, the pump still thinks that you're giving them U100, so it's just really important to adjust the pump settings to account for that difference. So basal rates, you'll need to decrease the basal rate in half, and then for the ISF and the carb ratio, you'll need to double both of these values to allow for the same unit amount to be given with the U200 in the system. Application to clinical practice. Automated insulin delivery systems are viable options for patients with type 2 diabetes to achieve improved glucose control, and especially in those with higher baseline A1Cs. We saw with all these systems, precise carb counting is not necessary. And then automated insulin delivery is not really seeming to increase the risk of hypoglycemia. And then close follow-up during pump initiation is likely preferred, especially as these are new systems for people and there's lots of learning to be had. So that wraps up kind of our lecture portion. We do have some cases to follow, but can answer any questions or any thoughts before the cases. Should get here. Well, I made fun to get the virtual room set up, but thank you all.
All right, so we'll start with the Tandem case. So if you all want to pull that out.
Hi, everyone. Thanks for staying on. We're just getting the slides pulled up for the virtual. Slide 82 or 81, sorry. And then the cases were shared in the chat. Wonderful, thank you. Here you go. Great. Thank you. All right, so hopefully everyone is able to access the pump reports through the chat. And if you have any difficult viewing or want a copy later, you can let us know and we can make sure to share that or get that to you. So we're going to talk about a case for each pump system. So we'll start with the Tandem Control-IQ case. So I'll just kind of read them and then we'll probably ask for any thoughts as we move along the case. So HE is a 46-year-old male with type 2 diabetes diagnosed in 2011. It was complicated by neuropathy and nephropathy. He moved from California and established care in the endocrine clinic in July of 2024. He requested to start an insulin pump. He met with an educator and chose the Tandem X2 with Control-IQ. He started on the pump in August of 2024. He eats 2 meals a day, with his largest meal being lunch, and eats various snacks about, pretzels, tortillas, chips, nuts, cheese, and bananas, especially more on the days 5 to 6 following his Mounjaro injection. In terms of carb counting, he has carb counted in the past, but has gotten out of the habit. The educator did complete a carb assessment tool and the patient did okay with the carb counting. Pre-pump medications, he was on Ozempic, which was switched to Mounjaro 7.5 milligrams weekly, Lantus 58 units, Humalog 12 plus 2 before meals, Metformin 1,000 milligrams twice daily, and Jardiance 25 milligrams daily. All right, so here's his Dexcom data from his time before starting the pump. You'll see he was 31% in range with a GMI of 8.2%. Here's what his Tandem order form looks like. So again, we entered in his weight-based dosing. So he was 214 pounds and his total daily dose of insulin at that time was 94 units and based off of his Lantus and his Humalog use. So you can see that we decided between the weight-based dosing and the total daily dose of insulin. And it was either a difference of 70, 49, or 60 units per day, depending on which equation chosen. This particular patient did go with the total daily dose of insulin being used as, kind of as Erin was alluding to, if they felt pretty good about what they were taking and felt that the patient was pretty adherent, he may actually be requiring those units. So you can see how it's broken down. So half of the 70 units is in basal, which calculates to be out a 1.45 unit per hour dose. And then this, the Tandem system uses the rule of 450 and the rule of 1700 for its initial carb ratio and correction factor calculations. So those are calculated out to 6 and 25 respectively. So then here's where I'll kind of pull the audience and ask for some thoughts. So what do we think about his overall CGM use?
It's really, really good, 94% CGM use.
Yeah, absolutely. So maybe not as mere like areas of opportunity there. And then his time in automated mode.
Like 90%. So inactive about like 6% of the time. So not too bad. So like pretty good.
And then what about bolusing for meals? So as a reminder, he eats 2 main meals a day and then some snacks.
I mean, his basal, I guess the percentage of bolus is kind of lower than you'd expect, I would say, but um yeah.
Yeah, I totally agree. So he's only doing like less than 30% of his bolus. And especially with someone with type 2 diabetes, you would expect it to be closer to a 50-50. And then the 30 grams of carbs seems very, very low for an average daily carb intake, unless he was like on a really strict keto diet, which based off of the foods he reported doesn't seem to be the case, and it would expect him to be eating more than 30 grams. So maybe he's missing a lot of those boluses. How about his glucose targets? So here it's highlighted here, he's at 86% time in range. So he is meeting kind of greater than 70%, which is our typical target for a lot of people with an A1C of less than 7% as the goal. And then patterns of lows and highs. So there's, just because it's a little hard to ask over a virtual setting, but you can see that there is kind of this elevation following what's probably his breakfast or, his morning food. So then we can look at small picture reasons. What do you all notice from this report, especially in regards to those times where he's going high?
It looks, sorry, if anybody wants to jump in. He looks like he's not bolusing, like pre-bolusing for his meal. So he's like using a correction, and then once he goes high, maybe he'll bolus for his carbs with a correction in there, but he's not like pre-bolusing.
Yes, absolutely. That's what we were thinking as well. So thank you, Dr. Sharif. All right, so looking at our plan for hypoglycemia, so he's not really having hypoglycemia. I mean, I think that, I guess on the last slide, you see he sort of dipped when he entered in this carb entry, and that could have been, those could have been real carbs that he just administered late, or it could have been that he was, kind of panicking about having a reading up to 220 and then entered some fake carbs in to get a correction. So we could assess if those were fake carbs. And then educate the user to give a correction bolus if those were truly, in fact, kind of a fake carb entry. But other than that, really no hypoglycemia seen. From addressing a hyperglycemia standpoint, so with his overnight hyperglycemia, he seems to be pretty good. He's not currently using sleep mode, which we would have seen as like those clouds of disease on it. So we could always program it if we want to get a tighter control, but doesn't seem to be a huge problem right now. Hyperglycemia related to mealtime boluses. This is probably his biggest area of opportunity. So he should we should counsel him to announce all meals. Many boluses are missed before eating. Hyperglycemia following lows. So something we didn't mention was that he is manually suspending his insulin, which you can see in this purple box at right around 9 p.m. and you can see it the night before. So he is dropping low there, or he's potentially just worried going into bedtime that he's going to drop too low. So he is turning off the basal insulin delivery, which then is leading to higher blood glucose because he's not getting any basal insulin at all at that point. So we can tell him or counsel him to, avoid manual suspensions, especially as the pump is already going to be doing that for him. And then making sure that he's not over-treating those hypoglycemia episodes. And then after a correction bolus was given, doesn't really seem to be a reason for hyperglycemia for him. So summary from the case. So total daily insulin dose reduction after pump start. So his pre-pump total was 94 units. 2 weeks after starting, if I'm sorry for not pointing it out, but he
dropped all the way down to 46 units. So that can be a sign of, what we did see in these clinical trials, that patients needed less insulin when they were on these automated systems, which may be a result of like better absorption. It may be a result of better adherence now that some of the burden of the daily injections is reduced. But he did have a pretty significant drop in his insulin requirements. And then thoughts on lack of carb entry and glucose readings. So the average daily carbs was 30 grams, which again just seems pretty low. And 50% of his boluses were coming from Control-IQ autocorrection. So he could, to optimize his settings, could probably be pre-bolusing before meals. And then what setting changes can be made on the Tandem pump. So we do have a lot of options to change on this pump compared to maybe some of the other pumps, but we can change basal rate, carb ratio, correction factor, and then adjust his sleep activity. All right, any final thoughts on the Tandem case?
That's my guy.
Ooh, I'm not sure on that. Erin did build this case out, so I'm not sure.
Yeah, I can't remember if he was the guy that wasn't bolusing.
Oh,
And he turned his correction factor up, but I knew you guys had talked to me about the case. I couldn't remember if this was my guy or not.
Oh, yes. Yeah, well, the good news is he seems to be doing well. We actually do have another case at the very end that we have time to that may actually.
Can you flip back to his just like his daily readings, Allison?
Yeah.
Just really quick. I don't know if it's this guy or not. I will say I have one or two people that don't bolus and never planned to bolus, and you can get away with this by turning the correction factor up quite a bit. The key is you can't have them do what they did in the bottom slide where they start to bolus all of a sudden. And you have to be very clear with them. If you're not going to bolus, you can't all of a sudden decide to start bolusing, because that's what's going to happen. They're going to crash like that second bottom right circle, because then they're getting way too much. But the correction factor can hold them pretty steady, so they're basically just kind of wearing the pump. Not for everyone, but just as a suggestion.
Out of curiosity, how aggressively have you been increasing those correction factors?
I think I went from, a correction of maybe 1 to 40. I think I have him down to either 1 to 10 or 12.
Oh, wow. Okay.
Yeah, it works, but you have to be very, very clear that, look, if you're not going to bolus, you can't all of a sudden decide that you're going to start bolusing for full meals.
And is that something that you're finding specific with the Tandem pump system, like compared to the Omnipod that doesn't have the auto correction?
You wouldn't be able to do that with Omnipod because it's just not aggressive enough with its corrections. I don't have anybody with type 2 or that many people with Medtronic, to be honest with you. You probably could get away with it with Medtronic because it's similar. It's those correction boluses, right? The problem with Omnipod is it can't catch up quick enough. Whereas these can give these boluses and can be more aggressive and get it down.
Well, thank you so much for sharing that. That's really interesting.
Yeah, it's not a common thing I'm doing in any way, shape, or form. Nor would I recommend it for everybody. But in certain situations, this was a guy that I think came to me on a Tandem pump already and just was never going to bolus all that consistent. So I guess I don't think it is this one, but it does work. Now they have to have, certain insulin sensitivity, but just something to keep in mind if they're just not bolusing and they're not, doing what they're supposed to be doing. It is an option, but you got to be really careful.
Thank you. All right. Any additional thoughts on this case? All right, then we'll move into the Omnipod, which will kind of just take a different gear. So this is a case of a 45-year-old female who has type 2 diabetes complicated by neuropathy and nephropathy. A1C is 9.9%. That was checked in August of 25. Her current diabetes regimen was Tresiba 60 units once daily, Humalog U100, 32 plus 2 with breakfast, 20 plus 2 with lunch, and 20 plus 2 before supper, and then Ozempic 1 milligram weekly. She does report kind of poor adherence to her insulin and reports missing Humalog often. She is a 4-year-old and a freshman in high school, which keeps her busy and feels like diabetes has been a high burden for her. So here's looking at her insulin pump report. So again, similar to the last patient, she was, they did choose or to start with total daily dose of insulin rather than weight-based dosing. You know, maybe it could have potentially been considered to do weight-based dosing or the average of the two, just knowing that adherence was a concern for her. However, the total daily dose of insulin was selected. Also at this time, she was using 150 units of insulin per day. So with the Omnipod, that would mean she was changing the set like every 1 plus a few like hours each day, because it only, well, 1.5 days, I guess. So it was decided to change her to U200. So you just see kind of those conversions. So halving the basal rate, doubling the correction factor, and doubling the carb ratio. So looking at these same factors here, and for the sake of time, I'll probably speed through some of these. But you can see that her time in that the CGM active is not as good. It's at 76%. So that's something that we could kind of assess. What's going on with their CGM? Is she like losing a lot of connection? Is the line of sight not good? That she's losing communication? Is she having troubles getting it from the supplier? So can try to address some of those concerns. Additionally, automated mode, we see that she's really in manual mode most of the day. So at 66% of the day. So this may be a patient where she doesn't realize that she's going into automated mode as frequently as she is. So counseling could be really helpful for her. And then hopefully with that new software upgrade, we'll see less of this. In terms of bolusing for meals, she is probably doing a better job bolusing for meals than the last patient was, with 2.8 carb entries or meal entries per day and 120 grams in total. But her glucose targets are not being met. So her time in range is only 19%. And she seems to be having primarily highs, not really any lows. So identifying the cause of lows and highs. So she was set up on a meal estimation regimen using those custom foods and was instructed to do 30 grams for small meals, 45 grams for medium-sized meals, and 60 grams for large meals. And you'll see that she really is only entering in 30 grams and sometimes 45 grams and on the full report, if you look at it, was never entering 60 grams of carbs. So she, after talking with her, she was eating much more carb heavy meals than these boluses would suggest. So that was something for the patient, just requiring some education on kind of what a small, medium, and large meal looks like. So it was recommended that she start using the 45 to 60 gram options more frequently than these 30 and 45 gram options. Additionally, you'll see here in the yellow at the very bottom, this is what it looks like when she goes into manual mode. So she has the maximum basal delivery is administered. She gets an alert here letting her know that, that she's received the maximum basal delivery. It moves into automated limited mode for a little while and then switches her into the manual mode, and she just stays in that probably until her pod is changed again. So hypoglycemia is not a concern for this patient. So we're primarily looking at hyperglycemia. In terms of her overnight hyperglycemia, the target is already set to the lowest option of 110. So we're not able to really change anything with that other than optimizing her daytime settings that hopefully she's going to bend a little bit lower than she has been. For hyperglycemia related to mealtime boluses, we can reevaluate her custom foods and tell her to, administer those higher carb doses. Or if she was a patient who was actually doing a pretty good job with her carb estimation, then maybe we need to strengthen those carbs for each of her meal sizes. And then for hyperglycemia following lows, not really a concern with no hypoglycemia. And then after a correction bolus was given, we should educate her to make sure she's using that use CGM button to bolus when the glucose is high to take into account the trend and give her a little bit more insulin. So then we'll jump into our last case, which is our Medtronic case. And I apologize for going a few minutes over, but thanks for bearing with me. So NT is a 52-year-old male with type 2 diabetes diagnosed at age 34. He works second shift and sleeps from 3 a.m. and wakes up at 11 a.m. He reports missing doses of medications recently due to being tired from work. He's currently working 12 to 16-hour days and he works 7 days per week. His regimen is 2JO, 80 units once daily. Humalog U200, his prescribed dose is 50 plus 4 before meals. However, he's only taking it 1 time per day and taking a very large dose of 50 to 100 units per dose. He forgets to kind of take his other doses while he's at work. So you see this really significant decline when he takes that really large dose of insulin. He's also on Mounjaro 15 milligrams on Wednesdays, metformin 500 milligrams XR once daily, and Jardiance 25 milligrams daily. His A1Cs have been high in the 10 to 11% ranges, and that's pretty much how he has consistently been for quite some time. So he was interested in starting on a pump, and so he was referred to diabetes education for pump exploration, and he selected the 780G pump. You'll see here, this is what the 780G form looks like. It's not as automated, so it was just kind of a paper form copy. They ended up choosing the total daily dose of insulin rather than the weight-based dosing, just based off of the large amount of insulin he was using, as he's using somewhere between 130 to 180 plus units per day, but that dose was reduced by 25% to 128 units. He was already on U200, so we decided to keep him on U200, but the pump still thinks that he's using U100. So these dosing adjustments still do need to be made for him to use the U200 in the pump. So you can see, again, halving the basal rate, doubling the correction, and doubling the carb ratio. So since last visit, he started the Medtronic 780G and returns to clinic 2 weeks later, and he's happy with his insulin pump. His time and range were improved from that 19% to the 52%. His GMI is now 7.7%. No A1C was taken at that visit, though. He's forgetting to pre-bolus and is taking doses late, and he's continued on his other non-insulin therapies. So looking at his big picture, so his CGM use and his smart card time is, nearing 90%. So not perfect, but nearing that 90%. Does anyone have any suggestions for maybe what we could do to increase either of those, especially CGM wise?
Maybe potentially, I don't know if he'd be a candidate for some of the other CGMs that have longer wear, so he's, I don't know, wearing it more frequently. I don't know if that's the issue or if it's something else.
Yeah. I think so, just with knowing him a little bit. So adherence is has been a chronic thing for him that he struggled with, and he was before on the Libre system. So yeah, maybe switching him to the Instinct, something that he's more comfortable with or that he's used before, and giving him that 15-day wear may be helpful for him. Bolusing for meals. So he did improve quite a lot on his bolusing for meals, but he still did say that he was struggling with some of it. But now we see he's at least entering in doses 3.1 times per day. His glucose targets are not entirely being met, but they have increased quite a bit. And then his patterns of lows and highs. Luckily, we're not seeing too many lows here, but he is still having some hyperglycemia, better than before, but still having some. So looking at his small picture reasons, does anyone, have any thoughts on possibly some of these causes of hyperglycemia? So I think one thought that we had was just like the timing of the bolus might not be, could be optimized. So it seems like he does oftentimes go high and then takes these carbs late, which then, leads into hyperglycemia from the uncovered carbs, and then all of a sudden crashes back down. So having maybe not true hypoglycemia, but having these large drops. So potentially changing the timing of the bolus, and then possibly increasing or strengthening the carb ratio too, just as even when he is kind of timing it appropriately, it doesn't always seem to be covering it fully. So addressing overnight hypoglycemia, again, not really a true issue for him, but if some of those large drops are occurring because of late doses, we could assess for missed or late mealtime boluses. And then for overnight hyperglycemia, not really a concern for overnight hyperglycemia. Hyperglycemia related to meals, so assess if his meal bolus was missed, assess carb counting accuracy, and then strengthen the ICR if needed. And then other would be upgrading to the instinct sensor to improve sensor wear in automated mode, which will help improve glucose. So we are over time. We had kind of a bonus case included if anyone was interested, but you do have the reports if you want to look at it. But he is another example of a patient who is really not bolusing for any of his meals on the Medtronic 780G system and is doing very, very well. So time in range is 96%, with I think he enters in an average of 9 grams of carbs per day. So just kind of wanted to show how well these systems, work for some patients, even without carb entry, for those with type 2 diabetes. All right. Well, with that, any questions for me or any final thoughts on the material or these cases? Well, with that, thanks for staying a little bit late, and I hope everyone has a good evening here.
Thank you.
Thanks, Allison.
Thanks. Bye.